The plans for a heart institute at St. John's Hospital seemed to die with Dr. Harp. Then, in 1979, Dr. James Dove was chosen to continue St. John's tradition of excellence and compassion in heart care.
From the Prairie standpoint, we look at the 70s, that's sort of the formulation of this concept that we ought to have a heart institute in Springfield, that it was a place to grow a large program that could serve the region, but also develop a national and international reputation. I think in the 1980s was sort of the assembly of the team. And we sat in a room trying to decide what we should call it.
After the first meeting, it was about 20 seconds, and it deteriorated into just comedy, and we were you know, the heart throbs and all this kind of stuff.
The Prairie happened to be one name, and we put it up on the board. And we even have trouble spelling it. We weren't quite sure how to spell it.
George Taylor, one of the original four, said, look, I'm going to write the word Prairie on the board. If it's still on the board in the morning, if nobody's erased it, that's going to be the name of the group.
We were concerned how that's going to look on research publications like for Hopkins and Boston, and what are they going to think about Prairie? Does it sound too corny?
I didn't like the name Prairie. It sounded funny to me at the time.
But we said, well, this still is sort of the picture of what the Midwest is all about. So we said, we're going to leave the name up there. If it's not erased by morning, that's the name. And that's how it happened.
As their symbol, the Prairie Heart Institute adopted blades of prairie grass over a heart to represent compassionate cardiac care for the people of the heartland. The 1980s was a decade of expansion for both cardiac medicine and the Prairie practice. Dr. Harry A. Wellens, Jr., a cardiothoracic surgeon, followed to Springfield other associates from the University of Virginia's medical school.
I came to Springfield, Illinois in the summer of 1982. At that time, we were using 3 operating rooms in the area of the hospital that now is used for general surgery and other surgical procedures. At that time, too, there were roughly 700 heart operations done. Since that time, the program has grown to the point that we do between 1,500 to 1,800 heart operations here at St. John's every year. And moving out of that facility into an operating suite that has 8 operating rooms. The operating rooms are designed specifically for cardiac surgery.
The growing Prairie practice during the 1980s laid the groundwork to bring quality heart care and patient and physician education to underserved areas of rural Illinois. The innovative plans for community outreach brought Dr. Frank Michael to the practice.
One of the things that we saw immediately was that we were in a large semi-rural area, and there was a need for outlying heart care in a number of smaller communities. And one of the initial things that we tried to do was to develop some network clinics in smaller hospital areas. And this was an excellent opportunity for the smaller hospitals to have cardiology consultants available. It was an outstanding opportunity for us to get to know the primary care physicians who sent us patients from these small areas. The network now has gone from us just being itinerant visitors, if you would, to smaller community hospitals, to actually developing full-time cardiology programs in some of these hospitals as well.
The network of community clinics set the stage for a dramatic breakthrough in cardiac medicine, pioneered by Prairie cardiologists.
The biggest breakthrough in emergency medicine that I've encountered at St. John's in my 19 years here is the ability to stop a heart attack. When I was a resident or on the faculty at the University of Rochester, that was one of the most frustrating problems we encountered. Somebody having a heart attack and a progressive downhill course to death or severe disability. First with thrombolytic agents, these clot-busting drugs, and now with balloon and stent approach, it still gives me chills to see a heart attack stopped. Streptokinase was the first drug to use to break up clots causing a heart attack. If this drug was infused through a catheter up to the heart, that it would dissolve clots causing a heart attack, and we could stop the heart attack in the cardiac catheterization lab. We all proceeded to do this on an experimental basis, and then it became FDA approved. It became apparent in our practice, though, that so many patients lived in smaller towns outside of Springfield that it was not practical to rush them all by ambulance or helicopter to the catheterization lab day and night. We decided fairly early on that we would like to try to get a more practical approach by giving the drug in a vein in a simple intravenous line. It may sound simple, but that was very controversial at the time because of the risk involved and the chance of fatal bleeds. We were very grateful to SIU and the Human Investigations Committee to give us permission to do that research. And their courageous decision, I think, saved many lives and prevented a great deal of disability. For instance, 2 years after we started, I received a call from a professor at Ohio State University who still could not get permission to do this investigationally. The other area of cooperation that occurred was with the primary care physicians around central and southern Illinois. They were essentially co-investigators with us. Some of the small community hospitals in central and southern Illinois had more experience with this experimental approach than most major university centers, and perhaps all university centers in the country.
The development of a clot-busting antithrombolytic drug therapy to stop a heart attack established Prairie cardiologists as international leaders in medical research. Clot-busting drug therapies introduced new roles for the cardiac catheterization laboratory.
Over the years, the focus of the cardiac cath lab has changed. Previous years, we were focused almost exclusively on diagnosing problems with coronary arteries. Today, because of new technologies, new techniques, we're able to fix and solve the problems with coronary arteries at the same setting. Nowadays, with modern techniques, a simple diagnostic procedure, the patient may not spend more than 4 hours in the hospital. And in terms of the interventional procedures that we do, that is the procedures that we undertake to actually correct the blockages in coronary arteries. We initially started off with balloons, and then major developments ensued with the use of devices to cut out or remount coronary arteries, then major advances with coronary stents. And companies come to us all the time to test out their products because of the large volume place that we are.
The expanded role of the cardiac catheterization laboratory, the increased depth of cardiac services, and the growing needs of the Prairie practice set in motion plans for a new facility.
Actually, in the early 1980s, we felt we needed a building, and that's when the pavilion was built, actually. But the pavilion was built to house many different practices and physicians. We had space for 8 physicians in the pavilion office. But as the practice continued to grow, and as reputation continued to grow, we kept adding people. We realized that the only way to do this was to build a building that could sort of be the highlight of the cardiac program. We tried to decide what we want. We wanted office space, we wanted educational centers, we wanted prevention space, we wanted operating rooms and cath labs. When you put all that together, it came into this vision of building this building of this size so that patients could identify with the program. They would be one heart building they could go to, and all services could emulate from that building.
A groundbreaking ceremony launched the new construction in 1996. It took 2 years to build the 165,000 square foot facility. The opening and dedication of the Prairie Heart Institute was celebrated in July 1998. Visitors entering the ground floor of today's Prairie Heart Institute are soon aware of a fresh approach to cardiac medicine, education, cardiac disease prevention, and recovery. The first floor features a state-of-the-art cardiac rehabilitation facility, prevention and treatment services, one-on-one nutrition counseling, and healthy eating programs for the public. The 300-seat conference center hosts educational functions and meetings. All patients and their families come to the 5th floor for patient registration. This floor also features a lab and X-ray facilities, cardiovascular diagnostic services, and 36 exam rooms. Over 95,000 procedures are performed each year in the cardiovascular department. Cardiac surgery services occupy another entire floor, with 8 cardiac surgery suites, a 16-bed recovery area for 24-hour recovery, and office space for cardiothoracic surgeons. About 2,800 cardiothoracic procedures are performed here annually. About 1,900 of these are open heart procedures. Another floor is dedicated to cardiac catheterization services. There are 7 cardiac cath procedure rooms, 2 of those for catheterizations performed on an outpatient basis, and 19 private patient prep rooms. There is also office space for cardiologists. About 10,000 diagnostic and treatment procedures are performed annually in the cath lab. The new facilities have enabled doctors at the Prairie Heart Institute to develop new specialized clinics and treatment strategies for heart conditions that were only marginally treatable in the past.
The field of cardiac electrophysiology probably began in the year 1969, and within 2 or 3 years, through the efforts of Dr. Arnie Carvalho, cardiac electrophysiology had its beginnings here in the Springfield area. Since then, the field has grown tremendously to the extent that we are now able to identify and cure many heart rhythm problems that could only be previously managed by medications. To help meet this growing need, St. John's and Prairie Heart Institute have been able to provide us with a very technically advanced electrophysiology laboratory that we're in right now. In most of what we do, the end result is a cure. As far as having medical problems, it is very rewarding to know that they don't come back.
Nationwide, approximately 3% of emergency room visits are prompted by a complaint of chest pain. From a cardiologist perspective, it's very important for us to sort out whether that pain is due to a heart attack or being at risk for a heart attack, or whether it's caused by another problem. We instituted the Chest Pain Center here at St. John's in 1997 to help facilitate the most accurate and fastest possible diagnoses for patients presenting with chest pain. We've brought together the laboratory facilities and the stress testing availability to be able to provide stress testing 7 days a week for patients with chest pain. And in fact, I don't know another facility in the country that has nuclear stress testing available on Sundays. This has allowed us to have roughly 72% of patients presenting at the Chest Pain Center go home within 24 hours of their presentation. When you track our experience, you can see that patients tend to do quite well and the care is cost effective. You get to the problem quickly, you can solve it quickly. And of course, we track our own experience so we can try and learn from it, see what works the best, and keep enhancing what we do. And I think that continuing look at our policies and procedures is reflected in the good outcomes.
At St. John's Hospital, the philosophy that no patient should ever be turned away directs that if there is a need, the program will grow to meet it. In 1997, the heart program began a new chapter in its history when Tammy German received the first heart transplant at St. John's. In conjunction with the transplant program, the Prairie Heart Institute's transplant specialists began a heart failure clinic to bring new hope and treatment options to those suffering from progressive heart disease. Today, many of these patients return to living productive lives and avoid entering the heart transplant waiting list. The key to successful outcomes for all cardiac patients is a renewed focus on wellness. As the heart care program enters a new millennium, the approach to heart care remains holistic, embracing both the patient and the family.
Cardiac rehabilitation has a tremendous impact on the management of patients with both heart failure and patients that have undergone heart transplantation. It's clear that the objective for both patient groups is to get them rehabilitated back into their own normal environments. Cardiac rehabilitation gives patients a perspective on self-empowerment, participating in their own disease process, and hopefully transferring that into improved quality of life and improved survival. There is a mind-body connection, and there's no doubt that an unhappy head makes for an unhappy heart. What I've learned from the patients while I've been here is the breadth of approach that's needed to deal with cardiovascular disease. It's not at the end of the prescription pad, it's not at the end of the catheter, it's the encompassing of the whole patient and the family that go up to make the medical problem that caused his presentation.
One of the things that I really enjoy about working at Prairie Heart Institute is that we have a team approach to patient care, and I think that provides the best possible care in a compassionate way. We are able to incorporate the patient and the family into the team. It involves a very good support staff of professionals that provide this care, a team approach to patient care. That's something that's unique in our program. that allows superior results and patient satisfaction.